I want to welcome everyone to our monthly Endo support group. I'm glad that you're back, or if you're new, welcome. For those of you that don't know me, my name is Jeanette Rodriguez, and I'm the program coordinator at the Riverside Medical Clinic Charitable Foundation. I want to thank our wonderful sponsors, the Riverside Medical Clinic and ADVI, for their support. For those of you that have friends that might be missing this at the moment or just really busy, we will be posting this replay on our channel, and I'll go ahead and give you the links to that at the end, as well as on our website. Let's see. Again, we will have a Q&A at the very end of the webinar, so go ahead and enter your questions in the chat box. I will be pulling those questions out and getting them answered for you. Other than that, I think we're pretty much ready to go. I would like to introduce our guest speaker, Dr. Shanti Mohling. She's a skilled gynecologic surgeon and a frequent speaker at national gynecology meetings. She's a passionate woman about women's health and received the Golden Apple Award for teaching as the chief resident. Most recently, she received the APGO Award for excellence in teaching obstetrics and gynecology. She is an expert in minimally invasive gynecologic surgery techniques, helping women with life-changing procedures for pelvic organ prolapse, endometriosis, pelvic pain, and more. So I'm gonna go ahead and give the floor to Dr. Shanti.
Thank you, Jeanette. So I really appreciate being able to be here, and I appreciate the invitation very much, Jeanette. And welcome. It sounds like I've got people coming from all over the country. We heard a widespread there from Alaska, from Utah, New York, and so forth. So welcome. And as you can see, the topic today is really about getting the most from your visit with a gynecologist. And what really inspired this this topic was over and over again hearing from patients or hearing from friends of family who would call because they have access to me, and I'm always happy to talk with friends, but hearing over and over again about patients going in to the provider saying, I am in debilitating pain, I can't go to work, I'm absolutely, can't sleep through the night, I'm in so much pain, and all of these issues, which we'll talk about further today. And having a 15-minute appointment, often not an exam or a very cursory exam, and really just being offered a packet of pills and sent out the door. And I don't feel like that's enough to address pelvic pain. So I put together this talk, and I think I'm speaking mostly to people with pain, not so much today to other providers, but I do think that providers, and this I emphasize in the teaching capacity that I have, providers also perhaps could learn to do more in terms of really taking time and listening to the story from you. So I'm going to start moving through my slides. As Jeanette already told you, I'm Shanti Mohling, and I currently am working in Portland, Oregon at Pearl Women's Center in a private practice. I have no financial disclosures, meaning I don't receive funding from any pharmaceutical agency, no surgical agency, so I implicitly don't have bias in my presentation today. So my goal, and we can all read it together, but is how to teach you how to approach your visit to the gynecologist or provider when you have chronic pelvic pain, and how to get the most out of that visit. What information can you give me or another provider that's going to help develop that best diagnosis and plan for you? Everyone's pain is unique. I am reminded of that every single day, that someone comes in and it's not all just endometriosis of the right ovary. It could be endometriosis, it could be a number of other things, which we'll elaborate as we go through the talk. And then I want you also to understand, what is a reasonable evaluation? What does that exam look like? And what should it entail? So a little bit of my background. I did my residency in obstetrics and gynecology at the University of Colorado. I practiced as a generalist physician in OBGYN, delivering babies, doing surgeries, taking care of pelvic pain, but really as a generalist in New Mexico for nearly 15 years. And then I wanted more. I wanted to be able to give more to my patients and have the skill set to do that minimally invasively. So not to have to cut someone open, but always, always, almost always be able to do it through tiny incisions or laparoscopy if they need surgery. So I did a fellowship in minimally invasive surgery, and I did that in Tennessee and worked with some of the pioneers of minimally invasive surgery. I then stayed on in Tennessee and was associate director for the fellowship there, and also director of gynecology for the residents. And after that, I decided to come to Portland. But I want to share one other detail of my history, and that is that before I even went to medical school, I was a massage therapist, and I took care of anyone, men and women, some of whom just needed sports massage, but some of them who had pain. And so that was my first indoctrination into understanding certain pathways of pain and how the body can hold on to pain, and one aspect, which is musculoskeletal. So a little background about endometriosis. I know that often in your talks, as I reviewed some of the YouTube videos from previous speakers, that you've learned a lot about the general aspects of endometriosis. So we'll review that a little bit, but endometriosis affects 1 in 10 of females during the reproductive age, and the development or the etiology or how it develops in a person is very complex, and there are many different opinions about it. What is endometriosis? Traditionally, we think of it as a dysfunctional attachment of the cells that would normally line the uterus outside the uterus. So a little more on that right here. I'm going to see, can you see, hopefully you all can see my cursor. Can you see that, Jeanette? So this is the uterus right here, and here's a fetus. And let's say that's a growing baby girl, XX female. And inside that growing embryo, we think when there's going to be later endometriosis, are cells that normally would end up inside the lining of the uterus, and they end up, you see over here on the right, where I am over here, in between, say, the uterus and the rectum. Or they can end up on the diaphragm, or they can end up even in very rare places like the heart or the lung or the brain. And so that's called Mullerianosis. That's one major theory. And so the reason I share that is part of how we understand that if we remove that, it shouldn't come back because it happened in embryo, in utero during development. Another way we think that it might occur is spread from the lining of the uterus through the lymphatic system. And that's a less popular theory, or through the blood system. One of the other main popular theories, and it may be a mixed pathogenesis, we don't know, but is that cells, when we have a period, go out the tubes and onto the ovary or into the body cavity, and that causes, under certain circumstances, endometriosis. So the next slide is just that the most common concept currently among surgeons is this Mullerianosis theory, where you have it developing in the embryo, in the uterus. So this shows the uterus of the baby, rectum, uterus, and this lining cells developing. You think that showed up, Jeanette? You can see my cursor, okay. So that's to give you an understanding of why do women get this? So there's a lot of questions we don't know why. We think it's partly genetics. We think it's partly environmental. And I really believe it's an overlay, that there's an overlay of environment plus genetics. And you could have perfect environment and super strong genetics, you'd still have endometriosis. Or you might have perfect genetics and like the worst ever environmental pesticides in living next to a pesticide farm or whatever, and then you might still get endometriosis. So it's it's a combination, I believe, of environment and genetics. So 6 to 22% of women were found, this is in a major study, meta-analysis study, showed that 6 to 22% of women at the time of tubal ligation had the finding of some endometriosis. We think that 80% of women with chronic pelvic pain, if you do a laparoscope, you will find endometriosis. 65% of women with infertility, and all of that amounts to 10% of the female reproductive population. So I think that the important thing we're going to talk about here today, moving forward, are you, those of you listening, and your symptoms and how you might get to a diagnosis, and what would that look like to get yourself onto a journey of healing. So what are your symptoms? Everyone's symptoms are different. So do you have pain with your periods? I saw someone today who hasn't had a period in a couple of years because they have a Nexplanon in their arm, which suppressed their periods, but yet they still have pain. And it feels like it might be endometriosis. We don't know yet. We haven't looked in there yet. So is it pain with periods? Is it pain every day, or is it just cyclic? Is it pain with sex and intercourse? Is it pain with penetration, or is it pain with orgasm? Does it happen with exercise? Is it pain just with normal activity, like walking around at the grocery store? Does that cause pain? Or is it pain with a full bladder? Do you have pain when you have a bowel movement? This is really important because oftentimes we see endometriosis invading the bowel, and to the extent that we even need to remove a section of the bowel where that endometriosis has already invaded. Sometimes we can shave it off, but sometimes the presence, I believe, the presence of endometriosis within the cavity creates enough inflammation that that too can affect the bowel movements and cause pain. Is there neurologic pain? Is it felt going down the leg? Is it felt radiating through the pelvis or into the hip? So each of you, as you're listening, you might take a few notes, because that's going to be an important piece of your story, your own personal pain profile, if you will, your endometriosis profile, and each one is individual. So as we're talking about that, I'm wondering, what is your story? And I want each of you, as you're sitting there today, I can't see your faces. I wish I could see everyone's faces, but what is your personal story? Think back to that first time when you knew something was terribly wrong, when you had debilitating, incapacitating pain. When was that? When did you first feel that? Where were you? What were you doing? What happened? What did you have to do? I'll give you an example from my own history. I don't know if I ever had endometriosis or not, but I had debilitating periods. And I can remember I have a memory of the most intense time when I was at a conference and I had to leave, and I had to be in like fetal position in my bed, and I was already an OBGYN, and I was like, what is going on? What is going on? And there are other things that can cause pain, but among them, especially when it's a debilitating period, it can be endometriosis. So think about your story, because when I have someone sitting, if you're sitting in my office, I want to hear your story. It's going to help guide me to putting together all those puzzle pieces that create, as I said, your pain profile or your endometriosis profile. So these are the details. We want to think about how pain is. I had someone today who described that she had something new, that usually her pain is just deep cramping, horrible pain that's cramping. And she said now in this last 2 cycles, it's stabbing. So we can have an evolution of symptoms. And with endometriosis, it doesn't seem to be stagnant. It seems to be growing before it's treated. Is the pain sharp? Is it gnawing? Is it dull and constant? Does it change? Is it always in the same spot, or does it move? Does heat help? Does exercise help, or does stillness help? Is it pain with ovulation? Do you know if you ovulate? Or if you're on the pill, you probably don't ovulate. Or does a birth control pill help? Has someone put you on birth control pills, and do they help? And what other symptoms have maybe I've missed? Here again is another really important piece of the history that you want to bring to the table, and that is, does anyone in your family have endometriosis? We know from data and the literature that somewhere around 5 times the risk of having endometriosis if you have a first-degree relative. So in general, we think it's 1 in 10. So that goes to 5 in 10, right? Or somewhere much higher if you have a strong family history. So really important to talk to your family, talk to your mom, talk to your sisters. Did any of them have, did your mom have to have a hysterectomy for some reason? Is there a family history of this kind of process? We also are beginning to have more and more gene studies showing clusters of genes that are associated, but we don't yet have a single gene that we can say, oh, we'll test you if you have this gene, you have endometriosis. We don't have that yet. We're beginning to. Do you have other health issues that could increase your risk of endometriosis? So know that some of the autoimmune diseases in particular seem to be associated with endometriosis. And that'll include rheumatoid arthritis, psoriasis, inflammatory bowel disease, celiac disease. They don't all increase the risk dramatically, but there is a significant association. So if you or a first-degree relative have a history, a strong association with autoimmune disease, that's important for me to hear. And I think it should be important for your provider. So I want to tell a story about a young woman who came to see me, and this was a number of years ago. But it may sound familiar to many of you, and to me, it illustrates something that I see over and over again. But in this case, I have surgical images to show you that will help define the story. So, and I've changed her name. Her name is not Tabitha, but we're just using that name. It was many years ago. She's 29. And for years had debilitating periods. She would miss school, she would miss work. And this is a person who worked hard. She would soldier through much of the time, but really could not always do that. And had been to doctors, was told periods, your exam is normal. She was given birth control pills. She was never really taken seriously. And she began having worsening condition and painful intercourse, and even gastrointestinal distress, and was referred to me. And so we talked at length, and we did an exam. And I do, as I'm going to illustrate for you in some later slides, I do a really, really, I consider focused exam to try and find the exact source of pain. Because when you really are doing an exam, not everything hurts. It's very focused. It's generally when someone has endometriosis or interstitial cystitis or a specific thing, the exam is focused, and some things don't hurt and specific things really hurt. Well, on her, I could feel nodularity, meaning sort of rock hard area deep behind her cervix. On my vaginal exam, of feeling her uterus, which felt pretty normal, but behind the cervix, I felt this nodule. So we went and did an ultrasound, and so I will show you, I hope everyone can see my cursor, but this is the uterus, right? And this is the lining. This is the healthy, normal endometrium. And this uterus looks good. Like, I don't see adenomyosis. I think she has, a good looking uterus. And let me go back. I just about gave it away. But right here is where I felt that nodule. And I know this because as I did the ultrasound, I also put my fingers in to feel and confirm, because usually people say you can't feel this on ultrasound. You can't feel you can't see endometriosis on ultrasound unless it's like a big ovarian cystic mass, like an ovarian endometrioma. But this little area that's highlighted was exactly where her pain was and where the nodule that I felt on exam was. So she elected to have endometriosis excision surgery. And this is what it looked like. And so for some of you, you may not have ever seen endometriosis or the inside of a body. And so these dark things are endometriosis. And this large area is the nodule. And you can see that that looks kind of subtle, that maybe someone could miss that. It turns out this is endometriosis, all of this is endometriosis. This is a healthy, beautiful ovary. This tube was beautiful. This is healthy, normal intestine down below. This is a benign ovarian cyst, healthy tube. And then up here is the uterus. So as I'm looking in, this is behind the uterus. Down here would be rectum, up here would be uterus, and this is what we call the posterior cul-de-sac. And sure enough, that's where that nodule was. And this is what it looks like after excision. To you, it might not look so great, but it ended up feeling great to her because we removed all that endometriosis. So whenever when someone comes to me with pelvic pain, I don't just instantly, they'll be ready for the exam and I'll say, okay, we'll go ahead and start the exam, and they'll lie down and start to go into putting their legs up. And I'm like, no, hold on. I want to start from the top. And to tell you the truth, I don't just start with the abdomen. I usually start with the neck. And the reason I start with the neck, well, first of all, I look at the skin tone, I look at the eyes, the just general health and well-being, but I'm going to look at the thyroid, because thyroid problems can lead to menstrual problems. So I'm always going to start with the neck. And I work my way down and I get to the abdomen. And occasionally you do an abdominal exam and you feel a mass that's big enough that I can feel it on the abdominal exam, but might have missed because it's higher up. And I might have missed it if I'd just gone straight to the pelvic. But I also get a lot of clues. And especially when someone has had pain for years and years, they begin to have what we call somatic pain. So pain of the abdominal body wall, in addition to that organ pain. And that's because, well, we think it's because the nerves that come from the belly wall and the body go to the same nerve root as some of those organs. So we have the organ pain or visceral pain, and we have the body or somatic pain going to the same dorsal nerve root ganglion. So this is all neural, nerves are what are telling our brain we're in pain, right? So after years of having pain coming from the ovary, there's an overlap that happens, we think, and there may be some pain coming from the body wall too. So I always evaluate for that, as well as looking for masses and sources of pain on the belly. And this is something called Carnet's test. And basically, if you could imagine, if you do a sit-up and you make your abdominal wall rigid, I can't any longer feel deep down into your soft organs. I can only feel those abdominal wall. And if the pain goes away while I'm holding onto that belly wall, then I know that pain is coming from deep to the abdomen. If the pain intensifies, I need to think that maybe there's some abdominal wall pain in addition to the deep pain or instead of the deep pain. So this is a valuable little test I like to do. I'm going to just add something right now because it's coming to my mind, but we all in our lives have mentors. And one of my very first mentors was a man named Dr. John Slocum, and he's who taught me this test. And this man, so this will be in the late 90s that I learned from him, truly devoted his entire life to treating women with pain. I mean, he taught me in the 90s, so over 20 years ago, that at that time we all had pagers. He kept his pager on all the time for his patients because he was so committed to treating their pain. So that I just had to throw that in because he taught me about Carnet's test, and I just remembered him right now. So okay, so this might be an alarming picture for people if you're not used to seeing this, but this is a speculum exam. Okay, so this is a plastic one. I often have metal ones here, but in Tennessee I had plastic ones. And this view this is the cervix, and this is behind the cervix. This right here happens to be endometriosis coming through from the body. That corresponded to endometriosis on the inside of a body. This is another patient now, not the last one we just saw. And that led me to realizing I had to do full thickness excision to get it from the body wall and through all the way to the vagina. So sometimes endometriosis will actually present, and it underscores the importance of a really careful vaginal exam because it will give you clues to how to help care for someone surgically, at least in my case. If I see that, then I really am going to be alert for that. So this is obviously an image showing an exam, and it shows one finger. And a lot of times with pelvic pain, I will start with one finger. And that's because sometimes women with pelvic pain haven't been having sex because it hurts too much. And so it hurts a lot when I use two fingers. Sometimes I need to try and use two fingers anyway to really reach far enough. One finger is not as far as two. Two can reach farther. And when the pelvic exam is being done, in this part, right after you go in, not all the way up by the uterus. This is the uterus, this is the bladder. But these muscles of the pelvic floor can sometimes be the actual culprit in pelvic pain. And so it can be what we call levator ani syndrome or vaginismus. But when the muscles of the pelvic floor are in spasm or in chronic tension, they create just horrific pelvic floor pain that radiates deep into the whole pelvis, or sometimes down the legs or into the rectum. And there are very specific, like obturator internus, an adjacent muscle in here, classically refers toward the rectum as an example. And so when that's part of the pain, we need to address that separately, sometimes even with Botox injections. So I've used Botox to relax that pelvic floor and have had great success, really dramatically decreasing that sensed pain that is just like horrible low vaginal pelvic pain. But I can also feel the bladder. And when someone has interstitial cystitis, oftentimes the bladder will be tender on exam. I can feel the uterus, and I can feel behind the uterus to those uterosacral ligaments where those nodules I showed you the picture of earlier. This is again to underscore the importance of a rectal exam. And I think with endometriosis, it's the most important exam is the rectal vaginal exam. And this is an example of where that endometriosis can go between the rectum and the vagina and the uterus. And when we see it in here, it can be horrific or it can be mild, but it's in that rectovaginal space. And this is the same as that photograph I showed you of the surgical image. So this is the bladder, the uterus, the rectum, and then this in here, in this little area, is endometriosis. So that can be felt if I have a finger in the vagina and a finger in the rectum, I can feel that disease that is right in there, right in there. Hopefully you can all see that on your screens. So not all pain is caused by endometriosis. And there are times when I do an exam and I'm not sure, and we look inside and there is endometriosis, but there are also times occasionally where there isn't any. And so we have to remember that that doesn't mean there's no pain. It just means that that isn't what caused the pain. And I think that I've put 5 main causes of pelvic pain here. And this does not include acute pain, that you've got, you know, a pelvic infection or a torsed ovary or a tubal pregnancy or some of the classic things that cause acute pelvic pain. These are the main causes of chronic pelvic pain, mostly in women. But I also want to just say, as a caveat to that, that pelvic pain in trans men is also a really significant deal. And when it's combined, when endometriosis is combined with gender dysphoria, it should be taken very seriously. But we also are here mostly today talking about the female pelvis. So if I say female or woman, please know that I really am not trying to be limiting. But the 5 main causes of pelvic pain are endometriosis, bladder pain syndrome, irritable bowel syndrome, or IBD, which is different. Inflammatory bowel disease is like Crohn's disease and ulcerative colitis. And those 2 are associated with endo, and those 2 can cause cramping, horrific pelvic and abdominal pain. And then I want to add to the picture myofascial pain. Myofascial pain can be a huge part of pelvic pain. And I think in some ways, so my little massage therapy background brought me to a deeper understanding of that. But I think it's a very often overlooked component of pelvic pain. And finally, neuropathic pain. So let's look at each of those in some detail. And I'm going to take 1 second. I have my notes on each of these slides, and I want to make sure I'm not forgetting anything. So give me 1 second. All right, so we are good. We're also making appropriate time. I want to leave time for questions. So what is this picture? This picture is alarming if you are not familiar with looking at this kind of picture. But if you can see my cursor over here on the picture, this is a fine-looking uterus. Okay, this is a robotic instrument. I do robotic surgery, and I do laparoscopic surgery. I do both. But in this case, this one's a robotic instrument. And this is an ovary. It's actually not normal because this is a huge endometrioma. And that is when endometriosis invades an ovarian cyst and becomes a big chocolate-filled, very often painful cyst called an endometrioma. And these don't just go away on their own. They are persistent cycle to cycle. So once someone has an endometrioma, no amount of birth control pills or IUDs is going to make that go away. They tend to stay until you excise them. But as you look at this one, if someone wanted to keep that ovary, they probably could. You can see there's some good healthy ovary here, and you just got to remove that endometrioma. They don't always just hang off so nicely. That one is just asking to be removed. But back to what this slide represents. What does endometriosis tend to cause? Painful periods, often painful bowel movements on its own. Even if there's no true irritable bowel syndrome or celiac disease or inflammatory bowel disease, endometriosis itself can cause painful bowel movements. So if someone just came with painful bowel movements, I've got to think about I got to rule out each of those things or think about them as a collection of things, and as I sort out what's the exact thing causing your pain. Endometriosis can cause pain with intercourse. It alone can cause a painful bladder, or in addition to interstitial cystitis. It can also cause infertility, and it does this in a couple of ways. I believe, and a lot of the literature will support this, that the presence of endometriosis within the peritoneal cavity means the lining of the body, creates an inflammatory state that is hostile to conception and healthy pregnancy. And so just the presence of endometriosis can inhibit, not 100%, but can inhibit healthy fertility. But it can also cause terrible scarring of the tubes so that they don't function properly and can't carry an egg back to the uterus for pregnancy. Endometriosis can even be associated with chest pain. So a few weeks ago, I was operating with a colleague of mine, and endometriosis was on the diaphragm, but it penetrated all the way through to the lungs. So it required, we had a surgeon to come in to look laparoscopically through the lung, at the lung, to make sure, and we could see it on both sides. So all that tissue had to be excised and closed, because with every period, this person had chest pain. And some women will even cough blood during their period when there's endometriosis in the lungs. So sometimes you collaborate with other surgeons to treat these things. Blood in the stool, in the poop, can be a sign of endometriosis invading through the bowel, especially in the colon. And painful bowel movements aren't necessarily invasion of endometriosis through the bowel, but could just be superficially on the bowel. That too can be a symptom of endometriosis. And pelvic pain throughout the cycle, not as often in young women, but progressively as women get older, if they haven't had their endometriosis treated, they might have pain throughout the cycle. It may get so bad they have pain throughout the cycle. So I've mentioned interstitial cystitis a bit through this talk. And for those of you who aren't aware of it, it's a painful condition of the bladder. And we diagnose it with something called hydrodistension, where we overfill the bladder, look for these signs. And what this is the inside of a bladder. It's a photograph I took of the inside of a bladder. Following that hydrodistension, you see all these little spots that bleed. A healthy bladder doesn't do that. Symptoms of interstitial cystitis include frequency, urgency, and often I ask people getting up, if they get up at night, to void. And they're surprised. They're like, yes, I do. What made you ask me that? Well, 50 to 80% of patients with endometriosis are going to have interstitial cystitis also. And so I always ask that question. I've had some patients also who ended up not having any endometriosis at all, and their pain really turned out to be just interstitial cystitis. So it's really, really important that we include this in our evaluation. So pain on emptying the bladder and so forth. There are, the good news about interstitial cystitis is that many patients, men and women, but patients will respond often to our first line management, which is changes in lifestyle and increasing water intake. The big culprits are going to be caffeine, sodas, chocolate, alcohol, and spicy things. Sometimes citrus things are the biggest triggers for pain with interstitial cystitis, but there can be other ones as well. So we talked a little bit about this, but IBS symptoms and endometriosis go hand in hand. And I see a lot of posts online about endobelly. And I think that that's probably this bloating that can happen with patients with endometriosis. But I think it may also be related to food sensitivities, and that needs to be looked at. That probably also goes hand in hand with endometriosis. So thinking about foods we might be sensitive to, and either doing a test for that or keeping a food diary to see what is it that triggers this discomfort. So IBS can come in the form of constipation, it can come in the form of diarrhea, it can come in the form of alternating both of those, and also just bloating and discomfort. So it can be IBS purely, and it can also be endometriosis causing some of those symptoms in my experience. So myofascial trigger points, this is this slide shows a first basic understanding for people of how trigger points can contribute. So these are trigger points on the abdominal wall, but as I mentioned earlier, there are pelvic floor and vaginal wall trigger points that also have referred pain patterns. What's interesting, if you look down at this one's in pyramidalis, really low down, but the pain it causes can be moving all the way up. And then these trigger points are in the rectus sheath. There are also trigger points in a big key muscle that's a hip flexor called the iliopsoas. And some of you may have had physical therapy and be familiar with this muscle, but it's a big pelvic floor muscle, and it can refer deep into the pelvis and cause a lot of pain. And it's harder to access. You can't really access it so well because the intestines are in the way. So it's hard to, you can't do trigger point injections with it, but you can stretch it, you can do physical therapy, and identifying it is key. Sometimes someone has one side that has a super, super tight iliopsoas, and it is one of the main sources of their pain. And so that is always important to rule out, is myofascial pain playing a role here? Is it the only thing that's causing the pain, or is it hand in hand with the other triggers for pain? And then finally, neuropathic pain. Really, we can say that all pain involves the nerves. That's how we process pain, is we receive nerve perception and messages from the body telling us that there is pain. And sometimes it's because endometriosis is entrapping nerves. Sometimes it is a mass, or one thing I didn't include here would just be a tumor causing pain. And sometimes it could be inflamed nerves from chronic viral infection, from MS, from diabetes creates neuropathies, or post-viral infection. So always important to consider whether when you go to the provider, do you have an area that on one side of your body, one area, like sciatic nerve pain, for example, or pudendal neuralgia. This is a pain deep in the vagina called pudendal neuralgia. Some of you may be familiar with that term. And these are neurologic components to pain, and important that we address. Okay, so as we figure out what the problem is, then we also have to plan. And for me, surgical planning involves sometimes just doing the procedure myself with an assistant, but sometimes it may involve a colorectal surgeon if part of the bowel needs to be removed, or a thoracic surgeon if it's on the diaphragm and all the way through the diaphragm. I'll do it on the diaphragm itself, but not all the way through by myself. And the important thing being that as we plan the surgery, we want to excise all of it if possible. Occasionally there's enough, it has to be staged, but the goal is not to go in, diagnose, oh, there's endo, burn a little, bye-bye. No, that's not gonna give long-term benefit. We really need to excise it. And that sometimes requires a team. This picture actually wasn't a team for endometriosis. I just chose it because it was working with another surgeon, but this was about 6 years ago when I was developing this laparoscopic guided transversus abdominis plane block, which is a block that I like to do at the time of surgery to help decrease the pain, the post-operative pain. And I see a real benefit. It's hard to prove. Pain scales are hard to prove, but we do have a recent publication of our TAP blocks on our robotic surgeries showing it's very efficacious. And I see a huge benefit in my patients after surgery. So this is to demonstrate endometriosis. You saw the picture I showed you where you could easily see ovaries, you could easily see the cul-de-sac, you could identify something. This is when you get in and it's stage 4, you can't really find behind the uterus at all. So this is the uterus, this is one ovary, the other one you can't even see. And this is intestines tied up in everything. Okay, so this is where you need you need to end up ultimately resecting some bowel probably. So this is when endometriosis is there a long time, progresses, and really becomes invasive. This is where you wish that this endometriosis had been treated 10 years earlier, when the person was 19 or 20, instead of waiting till this disease became so invasive. But if I knew I was heading into this, I would want to have a colorectal surgeon available on board to help with the what will be a little resection of a piece of colon. This doesn't always mean that there's going to be a bag. A lot of times we just do a staple anastomosis together, and the person doesn't have to have a colostomy or a bag. They just no longer have that horrible pain with their bowel movements. This is an example of a case where I had shallow disease of endometriosis on the diaphragm. This is the diaphragm and this is the liver. This did not go all the way through, so I was able to excise each of these spots and remove just the superficial endometriosis that was not penetrating all the way through to the lung. But had it gone all the way through to the lung, I would have wanted a surgeon who could look what's called a VATS procedure, and that's a video-assisted transthoracic laparoscopy. And so looking through the lung to be able to see if there's full penetration, and also to, of course, avoid injury to the lung itself. And then that person will need a short period of time with a chest tube. So once we've gotten through surgery, we still need a plan, because most of the time I find when there's been chronic pain for a long time, we need an ongoing plan to help us continue to heal. And sometimes that will be pelvic floor physical therapy. I really believe in the value of hypnosis and sometimes psychotherapy. Diet, nutrition is a mainstay. Absolutely. I think women who've gone through all of this have to absolutely take good care of their nutritional input. Consider an IUD such as Mirena or Skyla or Liletta. That's called a levonorgestrel IUD, a progestin IUD. Sometimes I'll use birth control pills for patients if that's their desire or they've done well with them in the past. However, they do have a high dose of estrogens that I worry about contributing to ongoing disease. Pregnancy, if desired or planned, is good for the post-surgical plan. And always exercise, yoga, support groups, things that decrease our cortisol, decrease our inflammation levels are important. So in conclusion, I really want to say, be your own best advocate in your journey with endometriosis. Ask questions, ask for a timeline. If all they did was give you birth control pills, say, how soon should these help? When should I come back? I want to come back soon because I want to feel better. Ask for an exam, ask for an ultrasound, or ask for a referral if you don't feel you're getting if you're not fully being heard. So learn to be your own best advocate. And I'll take any questions. I hope I saved enough time for questions, Jeanette.
Yeah, no, we'll make sure to answer all of them. That's a lot of great information, and we have a lot of good feedback, and so the questions are coming in. So let me go ahead and just ask them away. So the first question that I have here is, what is the course of treatment for a teen who has endo or suspect of having endo?
So I often see teenagers, and we'll go through the same scenario with the exam and the questions, and sometimes an ultrasound that I outlined here. And if the exam is really benign and the periods are the thing that's really bad, sometimes in teenagers, we're going to try a birth control pill. And if that doesn't help, then it's not just simple dysmenorrhea. Something else is going on, and sometimes we need to go look inside. Okay? Hopefully that helped answer. And I think with teens, you catch the endometriosis usually at an earlier stage. But I think with teenagers, if they're not responding to birth control pills or hormonal treatment like a IUD or birth control, you have to take it seriously. You have to say, what else do we need? We need to do something else to see what's going on.
Yeah. Yeah, I hope that does help. The next question we have here is, I had a hysterectomy because of my endometriosis. Should my daughter be put on birth control pills to prevent it?
So that's a great question. I wouldn't say necessarily just start birth control pills to prevent it. I think depending on whether the daughter has painful periods, what age the mom was. So adenomyosis also can develop post C-section, not just from a predisposition embryologically. It can develop later in life, post multiple births and post C-section. So I would not necessarily say that just starting a birth control pill because of that history. I'd need to know more about it. But do keep in mind that with adenomyosis, and for everyone listening, that really has to do with endometriosis that invades the wall of the uterus itself. And so that is a slightly different story. And in an older woman, I like to know when, how did that develop? And so I wouldn't empirically just automatically put a young woman on birth control pills myself. That'd be my opinion.
Okay, I hope that helped answer that question. Another one I have here is, I have severe cramping after orgasms that feel like labor cramps. Would anything else be causing this other than endometriosis?
Yes. So one thing that I would look at was whether the pelvic floor muscles were spasming. So I think an exam can help guide where is that pain that's being felt after orgasm. It might not have anything to do with the uterus. It could be the pelvic floor muscles. It could be endometriosis. So an exam is going to help guide that, and a little more history. So pelvic floor muscles, though, can spasm and cause intense pain even without endometriosis.
The next one is, how can we prevent reoccurrence of endometriosis and endomyosis after undergoing a surgery?
Great question. So we could sneak back to my slides here for a second. The post-surgical plan is key. And I think that number one is we need to fully excise the endometriosis. And so if your surgery was burn a little, biopsy, and not really excise all that disease, your pain will likely recur. If you went to someone who really deeply excised, then we need to think about nutrition, anti-inflammatory supplements, exercise, yoga, lifestyle management, and then sometimes hypnosis, sometimes physical therapy. What are the other components contributing to pain? And I really believe in having those implemented right away.
The next one that we have here is, we have so many. This is awesome. I'm so glad that everyone is finding this very useful. So this one's a little bit long. It has a lot of detail, but I think it's a great question. What would you say about initial telehealth exams due to COVID? Do you think an appropriate assessment exam can take place to determine next steps without a physical exam?
And then absolutely, yeah. Perfect. And then if there's more to the question, we'll add.
Okay, go ahead.
So, because of COVID, we started doing all over the country and world, really, we started doing more telemedicine. And so just today, for example, I saw 2 patients with whom I had had full telemedicine visits where we discussed history, we discussed family history, we discussed past treatments, past medical issues, the whole constellation. So I already had all that information. They came in for a very focused exam, ultrasound, and then plan. And so I think by the time someone comes to me with a telemedicine visit, I don't think it'd be very unlikely that I'd tell them not to come for an exam. I pretty much almost always want to see them ultimately for an exam, but I can at least give them that first run through of how valuable is it going to be for you to come in with the exam, and hearing the story and putting together the history through the telemedicine is a really great first step. And the nice thing is it because of COVID, it opened up our ability to begin to have telemedicine visits from even patients a little farther away who don't want to make the 2 hours into Portland, for example. So we're definitely starting that way. What's the second half of that question?
I think you answered it, but
okay, good. Okay.
But she continues. I had surgery in December of 2019, but some endo was left behind, and the specialist near me is only doing consultations via telehealth. What are your thoughts about moving forward with the additional excision surgery without scheduling a physical exam first?
So if I were the person who was the specialist and receiving you who asked that question, I would love some way to review the exact records of the surgery and hopefully see some photographs or video from that procedure. That would give me a good sense about how valuable it would be to proceed. If the person who did the first surgery wasn't comfortable with extensive excision and really just took a little, then it's very likely that ultimately we could do more with an exam. Now, that being said, that if someone has extensive bowel issues or pulmonary issues, I really want to figure out how I can assess that ahead of time so that I can get the appropriate team on board. The other thing is that because I also operated at an ambulatory center, when I choose to operate at the center, I'm making sure someone doesn't have bowel disease because I don't have a colorectal surgeon at my ambulatory center for same-day surgery. So I don't do my really advanced cases at here. So I really like to know ahead of time for surgical planning. But if I saw images from a previous surgery and could review those, that would give me a lot of information to potentially move forward. So I hopefully that answers the question with regards to the specialist in Texas.
Yeah. Let's see. Another one that we have here: is it possible for endometriosis symptoms to not be present until perimenopause, or would symptoms usually present earlier?
So that's a really good question. I actually have a chapter I did with one of my fellows on menopausal, not just perimenopausal, but menopausal endometriosis. And I think that one could have mild endometriosis that progressed through life and then the symptoms became much more exacerbated during perimenopause. Also, during perimenopause, estrogen levels are like this roller coaster. And I have seen estrogen levels like 800, 1,000. These are really high levels in perimenopause, which can drive endo. So I would say that the answer is yes. And the other piece of that answer is that this is when, in perimenopause, is when you tend to see progression of adenomyosis. And those symptoms are excruciating periods, heavy periods, little different from just endometriosis in the body. And in my opinion, in that circumstance, hysterectomy can be really helpful because we're talking about disease that's in the body wall of the uterus that you can't just excise without removing the uterus itself. So perimenopause, I think we tend to see more adenomyosis, but I could see a case for endometriosis itself worsening because of the fluctuation of hormones throughout the prior 10 years.
That's actually, it's something I haven't heard of. So yeah, that's, wow. I'm gonna go ahead and do two more because we're running out of, we're pretty much out of time, but I think these are such great questions. So we have one here. How does someone find a provider with expertise in managing endometriosis?
So that's a good question, and it's hard. I think in some communities there aren't people who focus their careers in life and love and passion on endo. But there is a Facebook resource called Nancy's Nook, and she has vetted a lot of surgeons to find surgeons in communities throughout the country who are focused on excision surgery and not just ablation or diagnosing and burning a couple spots. So that's one resource. I think that there is a very robust online community on Instagram. And by the way, I'm also on Instagram at Shanti Mohling MD. But there is a robust community, and my sense is that the people with endo and pelvic pain on this community are pretty sophisticated in helping each other out with finding excision surgeons. And your program and organization, Jeanette, also is another resource for people, it seems. You've hosted some excellent people to speak about endometriosis.
Yeah, for those of you that are new to this, our website at rmccharity.org, we do have a page dedicated to endometriosis. So we do have a lot of resources there that we like to update every month. And if there's something that's on there that maybe is not focused to what you're needing, we like to try to provide as much as we can. So if you ever think, hey, I think this would be great, or oh, I need this type of resource, we would love to connect you with, if it's either a doctor or a nurse, or just a resource in general that we can provide for everyone. Feel free to connect with me. With that being said, I'm going to go ahead and add Dr. Mohling's information, her Instagram, as she just shared, and then the website to the Pearls Women's Center, in case that you do want to learn a little bit more about her and her workplace and what they offer, as well as our information for our foundation, and where you can connect with our support group and different endo sisters. So I'm going to go ahead and add that now. And then at the bottom, I've also ended my email. So we have a few more.
Can we see that, Jeanette? I don't.
Yes.
Is it going to show up?
Yes, sorry, it's in the group chat. So you go ahead and click on chat.
Oh, okay. I don't think I have it.
You can go ahead and exit out of there. Go ahead and end your screen share, and then you'll be able to see it. So if you click, if you go to the top, you'll be able to see the view options. You can go ahead and end your screen share.
Oh, there we go. Okay.
Yeah. So once you go ahead and end that, you'll be able to find that toolbar, and you can click on the chat and see the information that I just posted.
Great. I should have ended that screen share a while ago. Sorry.
No, that's fine. So if anyone wants to get in touch with Dr. Mohling, please feel free to connect with her through those two platforms. I want to go ahead and thank you, Shanti, for coming on and sharing such great knowledge. And I tell this to every speaker every single time, that I always learn something new. Even though I do these all the time, I love learning in order for me to provide services with resources, right, for our endo sisters. So thank you so much for taking the time to do this.
My honor. Thank you, Jeanette. Yeah, and I wish I could see everyone's faces, but thank you for listening and participating today. And I appreciate really the great questions that people asked.
Yeah, thank you so much. I want to thank everyone for joining us. If we didn't get to your questions, we had a lot of questions this time around. Feel free to go ahead and shoot me an email. I'll try to guide you in the right direction with someone who can answer those. Maybe if you have time, Shanti, I'll forward them to you. And if
you can email me those questions, Jeanette.
Perfect. That way we can go ahead and make sure that everyone has their doubts answered. Yeah. All right. Well, thank you so much. I want to thank everyone for joining us. And I hope you guys have a great rest of the day. Again, this webinar will be posted on our page, on our YouTube page, as well as our rmccharity.org page. Okay. All right.
Thanks, Jeanette.
You're welcome. You're welcome. You guys have a great day. Bye-bye.
Bye, dear.